Thank you for joining me today. In this video, we are going to learn more about schizophrenia spectrum disorders. We are going to review the diagnosis criteria, psychotherapy, pharmacology treatments. We are going to learn and we are going to explain the epidemiology of schizophrenia, neurobiological pathology of the schizophrenia spectrum disorder. We are going to apply the DSM-5 treatment diagnosis criteria for schizophrenia and related psychiatric disorders. We're going to conduct a comprehensive psychiatric assessment to include differential diagnosis and mental health status examination. We are going to use of a validation symptoms rating scale. We're going to use the validated systemic rating scales. We are going to go over differential schizophrenia from mood disorders with schizophysiology and substance-induced psychosis and delirium, dementia, and other medical cause of psychosis. Because schizophrenia have psychosis features and also mood disorders has some psychotic psychiatric features. Substance-induced psychosis can have differential diagnosis with schizophrenia. Substance abuse can have also has a psychosis. Delirium can cause psychosis. Dementia can cause psychosis. Other medical causes can cause psychosis. So we are going to go over the differential diagnosis psychosis. We are going to develop individual treatment plan that integrate psychotherapy, psychopharmacy, pharmacotherapy, and psychosocial rehabilitation and recovery oriented care. We are going to go over selective appropriate the first line of treatment resistant pharmacology interventions while monitoring for side effects. We are going to go over how to recognize and manage extrapyramidal symptoms, tardive dyskinesia, neuroleptic malignancy, neuroleptic syndrome, hypoprolactemia, and metabolic syndrome. We are going to implement relapse prevention strategy, long-acting injection, antipsychotic medication, multidisciplinary care models. We are going to apply evidence-based treatment principles across the lifespan. Schizophrenia spectrum disorders are chronic psychiatric illness characterized by disturbances in perception, cognition, thought process, emotional expression, and behavior. These disorders are associated with substantial disability. These disorders impair social and occupational functions. These disorders reduce life expectancy and significantly cause caregiver and family burden. Schizophrenia affects approximately 1% of global population. Schizophrenia commonly begins during late teens and early childhood. Males generally present earlier, late teens to early 20s, while females often develop symptoms later, late 20s to early 30s. Modern medication and treatment extend beyond symptoms reduction and emphasize functional recovery that include education, employment, independent living, social relationships, and physical health and quality of life. So modern treatment extended beyond reducing the symptoms, and it emphasizes functional recovery, include education, employment, independent, social relationships, physical health, and improving the quality of life. Epidemiology of schizophrenia is approximately lifetime prevalence of 0.7 to 1%. Average onset of schizophrenia for males are 18 to 25 years old. That is when the onset begins of schizophrenia. For women, schizophrenia begins 25 to 35 years old. Slightly more predominant, so it's more schizophrenia is more in men than women. SI occurs approximately 5 to 10% of schizophrenia patients. Nearly 50% of schizophrenia population have co-occurrence of substance use disorders. 50%, that's half of the people with schizophrenia, they have substance abuses. That shows 50% of these are caused or exacerbated by the substance usage disorders. Life expectancy of patients with schizophrenia is short by approximately 10 to 20 years. So having a schizophrenia will cut 10 years to 20 years of your life, largely due to cardiac disease. Schizophrenia causes cardiac disease, it causes metabolic illness, smoke, and suicidal ideation. Because schizophrenia, people have to take antipsychotic medication for life. And this antipsychotic medication causes metabolic illness like diabetic, stroke, high lipids, blood pressure, weight gain, and cardiovascular disease like prolongation of a QT prolongation and stroke. Since 50% of the schizophrenia have smoking or substance abuse, it also leads to depression and SI. All this combined will approximately shorten the lifetime for 10 to 20 years. Neurobiological schizophrenia results from complex interaction among genetic vulnerability. So schizophrenia is caused by genetic vulnerability, neurodevelopmental abnormality, neurotransmitters like dopamine, norepinephrine, those called neurotransmitters dysregulation, ammonia activation, and environment stress. So let us review again. Schizophrenia is resulting from a complex interaction among, interaction of these: genetic vulnerability, neurodevelopmental abnormality, neurotransmitter dysregulation, ammonia activation, ammonia system activation, and environmental stress. One of those neurotransmitter dysregulations include dopamine. So hypodopamine or low dopamine causes hallucination, delusion, disorganized thoughts and behavior, and caused by muscarinic pathway called hyperdopaminics. These symptoms of hallucination, delusion, disorganized thoughts that caused by the more dopamine called positive symptoms of schizophrenia. So more dopamine will lead to positive or more positive of schizophrenia symptoms. Positive means more abnormal than the normal. So it's added. Let's say schizophrenia, somebody is talking to them, there is a auditory hallucination, an auditory hallucination, and auditory visual, and sometimes they feel bugs or insect is working on their skin. Delusion, disorganized thoughts, those are positive, is added to the person. Negative is when person is having it less than normal. More means positive, less means less than the normal. So more activity, more hallucination, more thoughts, more delusion, more. Those are agitation. Patient is doing more, hearing more than normal, acting more than normal, thinking more than normal. So those are positive. Less means they are doing less activity, they are withdrawal, they are withdrawal, they are isolated, they are not doing what they're supposed to do. So they are less than what normal person is supposed to be doing. So mesocortical pathway, also called hypodopaminic. Mesocortical pathway causes less dopamine. It called also less dopamine pathway, produces a foliation flat effect, no emotion in the face or no emotion or feeling. Cognition dysfunction, poor executive function. They have a poor. This present negative and cognitive impairment, negative symptoms and cognitive impairment of schizophrenia. Nigrostrial pathway, dopamine blockage causes acute dystonia. Dystonia is rigidity of the muscle. Parkinsonism. They have symptoms like somebody who have a Parkinson, because Parkinson is caused by dopamine blockage, less dopamine in their system. Akathisia and tardive dyskinesia. All these are caused by the nigrostrial pathways, dopamine blockage. Tuberoinfundibular pathways, dopamine inhibits the prolactin release. Dopamine inhibit the prolactin release. Antipsychiatric blockage causes hyperprolactemia. It causes hyperprolactemia. It causes amenorrhea. It causes glanconeria. It causes gynecomastia. It causes sexual dysfunction. It causes osteoporosis with the long-term elevation of prolactin. Glutamate hypothesis reduces NMDA receptor activity activity that may contribute to negative symptoms, cognitive impairment, and functional disability. Genetic heritability is approximately 80%. So if the patient is schizophrenia, one of their relatives has schizophrenia because it's 80%. Heritability is approximately 80% of patients with schizophrenia. Risk increases with affected relatives. If the twin siblings have schizophrenia, you are 50% higher to get schizophrenia. If one of your siblings who are not twin with you has schizophrenia, you have a 10% higher to get schizophrenia. If your parents have schizophrenia, you have a 10% of getting schizophrenia. For general population, it is 1%. 1% of anyone developing schizophrenia, anyone. They have a 1% chance of having a lifetime risk of developing schizophrenia. Even if your family are not schizophrenic, you have a 1% to develop schizophrenia. So even though it's a genetically 80% to get schizophrenia and it's hereditary, anyone can get the schizophrenia. Schizophrenia is a polygenetic. It's not only one gene that involved with schizophrenia. There is a number of genes and geno-environmental interactions involved with schizophrenia. So, what are the genetic risks of schizophrenia? What are the environmental risks of schizophrenia? Environmental risks factors include obstetric complications when the women are pregnant, if they have complications that can affect the child. If the mother have an infection during the pregnancy, that can have in a child development and leads to schizophrenia later in life. Childhood trauma can lead to schizophrenia. Living urban or big city upbringing can lead to schizophrenia because the stress is more. Environment interacting with outside activity and exercise is limited. Social adversity, if you are struggling in society, being poor, being minority, being whatever reason, if you are struggling social adversity, if you have going through social adversity, that can increase the schizophrenia, increase you developing schizophrenia. High potency cannabis use when you are a teenager and your brain is developing, if you use marijuana and cannabis, that increases you developing schizophrenia. Migrant or refugee or immigrant, they have a higher chance of developing schizophrenia because of the social adversity that they have. They live in urban community. They may have also childhood drama. They may have maybe heredit from their family, so that also they also have a higher chance of developing schizophrenia. Advanced parental age. If you are older lady and you have a child, that can lead to child being schizophrenia. So DSM-5 treatment diagnosis criteria of schizophrenia include 1 to 2 symptoms must be present for at least 1 month. So you have to have one or two, no, 2 or more symptoms of schizophrenia for at least 1 month to be diagnosed with schizophrenia, with continued signs of illness for at least 6 months. So the schizophrenia began, at least you had this schizophrenia symptoms at least 1 month, and it continued, it didn't stop, it continued 6 months. And this schizophrenia symptoms or psychosis symptoms have to be 2 or more symptoms. You have to have at least, you have to have one of the symptoms, must be at least you have to have one of these symptoms, but you have to have 2 symptoms or more to qualify being schizophrenic. If the patient have a delusion, hallucination, disorganized speech and thought, one of these, and other one for 1 month to 6 months, that characterize schizophrenia. Additional symptoms that include schizophrenia is ghastly disorganized behavior, catatonic, negative symptoms, functional decline. Functional decline must occur in one or more major life areas. So it's hard for you to walk, it's hard for you to have meaningful relationship or connection relationship. So it affects your major life areas. Those symptoms are schizophrenia related symptoms. Those meet the schizophrenia criteria. Positive symptoms of schizophrenia, as we talked about, is positive reflective excessive or distortion of a normal function. Distortion of a normal function. Delusion, it includes delusion. They have a delusion of persecutors. Somebody is after them, somebody want to kill them, somebody wanted to harm them. They have delusional ideas. They have delusional idea of grandiose. They think they are the richest man. They are the CEO of the company. They have special power. They are grandiose. Referential also they have somatic feeling of schizophrenia, delusion. There is a religious delusion that they are prophet, that they are leader of the religion groups. There is a erotomic schizophrenia, Nelehesti schizophrenia, status of insertion of schizophrenia, status of withdrawal, status of broadcasting. Those are the types of schizophrenia. They have delusionalis, and those delusional auditory hallucination is most common of hallucination. They also have visual hallucination, smell hallucination, gustation hallucination, tactile, which is the feeling of bugs or snakes on their skin. Those are some of the hallucinations. Disorganized speech, example of a disorganized speech is loose association, tangential disorganized speech, circumstantious neurologicalism speech, disorganized speech, glanty association speech, word salad speech. They also have disorganized behavior. This behavior include childlike behavior, agitation, poor hygiene, tracing, social disinhibition, inappropriate affect. They also have catatonia. Clinically sign include stubborn, mysticism, waxy flexibility, posturing, echophrexia, negativism, catatonia may occur in a schizophrenia, also may occur mood disorders. It can occur medical conditions and requires recognition and treatment. Negative symptoms of schizophrenia are associated with long-term disability and poor prognosis. So it's hard for you to recover from negative symptoms than positive symptoms. Negative symptoms include flat affect, poor emotional expression, affiliation, alanoia, sadness, associationally. Cognitive symptoms include, and common is working memory. It affects working memory. It affects executive function. It affects attention to details. It affects speech and social cognition and problem solving. These symptoms are strongly predict an occupational and social outcome. These symptoms strongly predict occupational and social outcomes. Schizophrenia spectrum disorders. It is brief psychiatric disorder. One day more than 1 day and less than, that's a brief psychiatric disorders. It is less than 1 day to 1 month. Person can fully return to baseline function. However, schizophrenia disorder takes 1 month to 6 months. Same symptoms as a schizophrenia. Schizophrenia, that is schizophrenia form disorder. However, schizophrenia symptoms persist for more than 6 months, and functional impairment is required to diagnose schizophrenia. Schizoaffective disorder. Psychosis occur with a mood episode, but also persist for at least 2 weeks without the mood symptoms. So even though the patient don't have a mood, they still continue. Delusional disorders persist. Delusional lasts at least 1 month without the broad symptoms profile of schizophrenia. So differential diagnosis of a schizophrenia are from bipolar disorder with schizo features, major depression disorder with psychiatric features, psychoaffective disorder, substance or medication induced psychiatric disorder, delirium, major neurocognitive disorder, temporal lobe epilepsy, autoimmune encephalopathy, encephalopathies, brain tumors, Wilson disease, Huntington disease, thyroid disease. All these have symptoms that similar to schizophrenia. Patient needs comprehensive psychiatric assessment. This assessment include chief compliant, history of present illness, psychiatric history, medical history, neurological history, review of medication, review of substance usage assessment, family psychiatric history, trauma history, because you want to figure out what is causing the schizophrenia, social and occupational functioning, housing and support symptoms, housing and support systems, societal and violent risk assessment. So mental status examination typically finds appearance. You want to assess the appearance of the patient. You want to appearance if they are poorly groomed, if they are groomed or barely groomed, and usual clothing, if they are wearing abnormal clothes. For example, if it's winter and they are wearing t-shirt, or if it's summer and they're wearing jacket and hats and boots and unusual clothes, those considered unusual clothes, or poorly groomed. That's the appearance that you see when you see the patient. That's what you want to assess. Behavior, you want to assess if they have any suspicious behavior, if they have any withdrawal behavior, if they are agitated, if they have any agitation and angry and irritability behavior. Speech, you want to assess the speech. Do they have disorganized speech, delay speech, poor poverty speech, or power of speech? Mood, you want to assess, you want to ask them how their mood is. Are they available? Affect, are they having a flat affect or inappropriate affect? Thought process, you want to assess loose association and tangentiality for thought process. Thought content, are they delusional? Are they paranoid? Perception, are they hallucinating? Auditory hallucination. Insight, do they have a poor judgment, impaired judgment, poor insight? Cognition, you want to assess executive dysfunctional. Screaming and rating scales. Useful instruments include positive and negative syndrome scale called Bansis scale. Brief psychiatric rating scale. Clinical global impression schizophrenia. Abnormal involuntary movement scale. Abnormal involuntary movement scale. You want to use those screening and rating skills. Banis akathisia rating scale or Baris. Simpson Agas scale or SAS. You want to evaluate, medical evaluation is recommended baseline study of white blood cell, CMP, thyroid, vitamin B2, vitamin B12, folate, vitamin D, urine toxicity for drug or substance abuse, pregnancy test, HIV testing when indicated, syphilis screening when indicated, lipid profile, H1C for cholesterol, H1C for diabetic, EKG for QT prolongation, for medication, and you want to consider MRI, CT scan, EEG, lumbar puncture when neurological or when a neurological or atypical features are present. Psychiatric treatment. The goal of a psychopharmacology treatment is to reduce psychosis, to prevent relapse, to improve function, to minimize side effects, to promote recovery. First line antipsychotic medication is the secondary antipsychotic medication, preferable for patients because of the low rate of EBS. Treatment-resistant schizophrenia, it is failure to respond to adequate antipsychotic trials that one is consistent of, and the clonazepam is beneficial. It's beneficial, most effective antipsychotic medications. It reduces SI, it improves treatment-resistant psychosis, it reduces aggression. However, it requires monitoring ANC, weight, A1C for diabetic, lipid, blood pressure, myocardial inflammation symptoms, constipation and low bowel function, seizure risks, because it causes all these symptoms. Also, you can consider long-acting injection antipsychotic medications. They improve the adhesiveness and reduce the relapse. This medication include Risperdal. Risperdal have a long-acting injection antipsychotic. Haldol, erbaprazole, paliperidone. You want to monitor side effects, adverse effects. Routinely monitor weight gain, weight conferences, blood pressure, A1C or fasting glucose, lipid profile, aim miss examination for tardive dyskinesia, EBS assessment, prolactin level, EKG evaluation when indicated, CBC and ANC for clozapine. Evidence-based psychotherapy medication is the cornerstone of a treatment, but psychotherapy and psychosocial interventions improve recovery and reduce relapse. So psychoeducation is recommended for every patient and every family. It improves understanding the illness, increases medication compliance, it improves recognizing early warning sign of the symptoms. It reduces relapse and encourage recovery. Cognitive behavior therapy for psychosis is also recommended, and it focuses on challenging maladaptive beliefs. It reduces distress-related hallucination. It improves coping strategy. It enhances realistic testing. It enhances understanding and reduction in a symptoms severity, and improves quality of function. Family therapy include education, communication skills, relapse prevention, and problem solving. And the benefit is it lowers the relapse rate, it improves medication adhesiveness, it reduces caregiver and family burden. Social skill training that targets communication, conversation skills, conflict resolution, independent living, cognition, remediation therapy addresses memory, attention, executive function, process speech. Assertive community treatment is recommended. Assertive community treatment is recommended for the patient with frequent hospitalization, homeless patient, poor treatment adhesive patient, severe functional impairment. Assertive community treatment provides multidisciplinary community-centered service with 24-hour crisis support. Supportive employment and education. Evidence supports that individual placement and support is model to help the patient obtain and maintain competitive employment and education participation. So it helps the patient to have employment and education. Recovery-oriented care. Recovery-oriented care modern schizophrenia treatment that emphasizes shared decision making, patient autonomy, goal setting, community engagement, quality of life, improving quality of life, and meaningful social roles. Relapse prevention strategy include continue antipsychotic treatment, long-term injection medication when it's appropriate, family involvement, substance use treatment, regular psychiatric follow-up, early recognition of sign of relapse or sign of schizophrenia, sleep hygiene, management of the medication comorbidity, medical comorbidity. Takeaways of our lecture include early treatment during the first episode is associated with improved long-term outcomes. Negative and cognitive symptoms often contribute more to long-term disability than positive symptoms. Long-term injection antipsychotic medications should be considered early for patients with recurrent, non-adhesive, or repeated relapse. Clozapine remains the gold standard for treatment resistant schizophrenia and for reducing suicidal ideation. Monitor cardiopulmonary risks routinely because cardiovascular disease is the leading cause of premature death for psychiatric patients. Combine pharmacotherapy with psychotherapy, family education, cognition remediation, psychosocial rehabilitation, and psychosocial rehabilitation for optimal recovery. You want to combine pharmacotherapy with psychotherapy, provide family education, family and caregiver education. You want to conduct cognitive remediation and psychosocial rehabilitation for optimal recovery. Schizophrenia spectrum are complex neurodevelopmental illness require long-term treatment and multidisciplinary management. Accurate diagnosis depends on a carefully applying of the DSM-5 treatment diagnosis criteria, comprehensive psychiatric and medication assessment, exclusion of alternative causes of a schizophrenia or psychosis. Antipsychotic medications, particularly second generation antipsychotic medications, remains the functional of the treatment, while clozapine is the treatment of choice for treatment-resistant schizophrenia. Long-term success depends on integration of a pharmacotherapy, evidence-based psychotherapy, family intervention, cognitive validate role in a promoting symptom remission, cognitive remediation and social skill training, supportive employment, and recovery-oriented care. Provider role is providers play a role in promoting a symptomatic remission, prevention of a relapse, optimizing a physical health, helping individuals with schizophrenia achieve meaningful functional recovery. Thank you for joining me today. I would love to see you in my next video. Please subscribe. Thank you.